Welcome to the webinar today on USG in Infertility, the Third Eye by Honorable Scholar of the Day, Dr. Ashok Khurana from New Delhi. We welcome you all to the sixth in the series of 7 days, 7 scholar, A to Z of Infertility every Friday, a Rewari Obs Gyn Society initiative. On behalf of Jacksonpal Pharmaceuticals Limited, makers of Cystelia M and Lycored Tex Sachet, I am Dr. Vipin Tyagi, along with my teammates, Dr. Deepika Chhabra and Mr. Amit Saxena. Thank you, Dr. Seema Mittal, President, Rewari Obs Gyn Society, convener and moderator for organizing this ICOG accredited webinar supported by Lalita Memorial Hospital Infertility Center, Rewari. We are privileged to have amongst us as Chairperson, Dr. Priti Kumar, Chairperson Safe Motherhood Committee, FOGSI, Dr. Poonam Varma Shivkumar, Professor and Head of Gynae, Mahatma Gandhi Institute of Medical Sciences, Sevagram, Maharashtra, Dr. Nirmala Devjyoti Sharma, Home Maternity Home Laproscopy Center, Bhuj, Gujarat. Welcome to the panelists, Dr. Bavin Balakrishnan, Fertility Specialist, Gifford Gynae and Fertility Center, Calicut, Dr. Dimpy Gombar, Senior Consultant Obs Gynae, Tirthram Shah Hospital and Vinayak Hospital, Delhi, Dr. Gagan Singhal, Senior Consultant Obs and Gynae, Narnaul, Dr. Nisha Agrawal, Senior Consultant and HOD Obs and Gynae, Meteor Hospital, Manesar, and vote of thanks by Dr. Deepak Yadav, Radiologist, Rewari. Welcome to the attendees. Please make note that this session is streaming on Facebook Live. The recording will remain on Jacksonpal's YouTube channel for reference and knowledge sharing, and it is brought to you by Jacksonpal Medical Services as a knowledge sharing initiative. We request all to please post your queries by text in the text box, which will be answered at the end. I will now request Dr. Seema Mittal ma'am to kindly initiate the session.
Thank you, Vipinji. Good evening, friends. As you know, ultrasound has become an important tool in the diagnosis in infertility because the pelvic structures, the uterus, the ovaries, and the endometrium all can be predicted so well. More so, the blood supply to the ovaries and the endometrium can be depicted and it can predict the outcome. And today evening excites me to know, and because in this journey of 7 days, 7 scholar, we have two scholars with us, Dr. Ashok Khurana sir, who has revolutionized the ultrasound as diagnostic modality. Definitely has got the third eye which can foresee things which no other can. We are privileged, we are happy and proud to have you with us, sir. Welcome, sir. And the chairpersons, they are so special. We have Dr. Priti Kumar with us. One person I admire so much, her zeal to strive for better and better. It has so many learning experiences for us. As chairperson FOGSI for Safe Motherhood, she has done nth number of programs, and that acts as constant stimulus for us to do better. And anybody who has witnessed the our Lucknow conference in 2020, the person would vouch for the spirituality and academic feast and the fun and food that we had. It was thoroughly enjoyable, and there is no word for your organizing skills, ma'am. We are really pleased to have. Can we have the CVs displayed on the screen? And another person who will be chairing the session is the person who taught me the first how to hold my hysterectomy clamp, and so many treats for the first DL to first CS to first hysterectomy to so many first. Dr. Poonam Varma, who is the professor and head of the department at Mahatma Gandhi Institute Medical Sciences, Sevagram, my alma mater. And another scholar who is chairing the session, Dr. Nirmala, who's been the topper, the bright student, but at the moment so stuck in family responsibilities and the work priorities that we had to really dig her out of that cave. Welcome, Dr. Nirmala. So over to Dr. Priti to introduce our scholar, the star of the evening, Dr. Ashok Khurana, sir. Priti, ma'am.
Thank you, Seema. Thank you so much for your kind words. Actually, that keeps me motivating and doing so many works. And thank you so for attending AICOG 2020 and taking me to those fond memories. It is always a proud moment to introduce a most favorite person, Dr. Ashok Khurana sir. I'm very, very fond of his lectures, and we really look forward to all his talks and deliberations. Thank you so much, sir, for being here. Thank you, Rewari Obs Gyn Society, for inviting us here. And during this COVID time, definitely we are learning so much on these virtual platforms. So it's a proud privilege to introduce Dr. Ashok Khurana sir. He's graduated and post-graduated from All India Institute of Medical Sciences. He's trained at Herlev Hospital in Denmark. Denmark is a beautiful place. I had been to Denmark in a World Congress on Women's Health Conference. It's a beautiful place. Currently, he's chairman and consultant in reproductive ultrasound at the ultrasound lab, New Delhi, India. He's practicing ultrasound in New Delhi since 1981. He is professor, no doubt where he is. He's professor for us. And then he has published so many, I think, n number of publications. I can vouch that he can totally replace sonology, that endoscopic surgery by his ultrasound caliber. So he's immediate past president of Society of Fetal Medicine. He's editor-in-chief of Journal of Fetal Medicine. And at present, he is the ambassador in India, the International Society of Ultrasound in ICOG. So welcome you, sir. Welcome. And he's going to talk on ultrasound in infertility. And I also agree that sometimes we unnecessarily do endoscopies in infertility patients. And that Dr. Ashok Khurana will prove in his talk. Thank you so much, sir.
Thank you, ma'am. Over to sir. Actually, no gynae conference is complete without sir's lecture, and it's our privilege, sir. Over to you, sir, Ashok sir.
Thank you very much. Thank you, Dr. Priti, for those very kind words. And my thanks to Dr. Seema and the entire Rewari Obs Gyn Society for having me over this evening. I do hope I don't put you off to sleep. And while my slides get shared, let me also take this chance to specially mention that I feel so nice that my colleague, Dr. Deepak Yadav, is also here with us. And it's always a pleasure to have somebody from your specialty there for moral support. And I love working with him. There's a lot of his excellent cases that I get to see. And sometimes I'm tempted to actually do a copy paste, but I said, no, I can't do that. But his reports are excellent. Thank you. And let's talk about the third eye with ultrasound in infertility. Now, when we look at infertility, the first thing we really need to think of in terms of this whole story is what is going on and what we need to truly do. When we look at the advances in ultrasound today, we realize that we have, is the screen now visible and we are comfortable?
Yes.
Yes, wonderful.
Yes,
so
sir.
we have 2D, we have 3D, we have new software in 3D which gives us images like this. We have the advantage of flow by power Doppler, etc. And yet we realize that we are not translating all of this into take-home baby rates or better outcomes. And then we start wondering, why is this? And why is ultrasound not used as much? Why is ultrasound value going down? And then we realize that one of the things that we are stuck with is the lack of awareness of what ultrasound can offer today. There's a tendency for everyone to have a very short-sighted approach to ultrasound scans. From a basic point of view, there's not money in ultrasound, like doing a single scan. Then there's a rush for IVF, and especially cycles fail. We don't regard very much about failed cycles. We don't audit ourselves or audit the patient. We don't recheck the patient's history. We just say, okay, we fast-track to third-party reproduction. Now, the moment we fast-tracking to third-party reproduction, then science fails. And because we don't know where ultrasound can help us in actually helping in a couple to achieve their own pregnancy, as I like to call it, it's very important. The other thing is that we often leave weekend work to an ultrasonologist who may not have the same degree of involvement or the same degree of experience to sort things out. After all, when you're planning a cycle, you do need an input at the right time in the right way by someone who has the expertise. And therefore we realize that we've failed a bit. And how can this be reversed? One is that we must realize that there's a lack of awareness by the radiologists on what can be offered. And there's a lack of awareness of the ART practitioner on what is on offer. And as a consequence, we end up losing out on a lot. And what we need to do is to be on the same page. We know that we have to improve skills and performance from both sides, from the clinician side as well as from everyone performing ultrasound. Knowledge is the first step. We must also then be on the same page. And for that, we have to have everybody involved, the ART practitioners, the CME activities that we all in together. And it's so nice to know that today the women's division of the IMA is part of this, so that the IMA also gets involved and so on. And then we realize that, yes, this is the best way that we can do. And therefore, we must move on in this particular thing. There's also this tendency on who should be doing ultrasound. And I firmly believe that anyone who knows how to do it should be doing it, but we must all have our skills. It's not that it's gynae ultrasound should be done by gynecologists, or radiology ultrasound should be done by radiologists. We must all skill ourselves, be on the same page, and then go ahead and then give unparalleled results and say, okay, this is how we will always work. There's no doubt that radiology people know how to look at images and possess superior technology, but it's very, very important that we have a good go at everything and say, yes, this is the way it should work. So when I was planning this, I said, yes, we must all be on the same page. And then I said, now, how do I get across my messages? And I figured, should I show this as a showcase of ultrasound for everyone? I said, no, it makes no sense. As a standard atlas to show everything, no, it does not make any sense. And I said, what I should do is, let me keep it at doable protocols that actually improve take-home baby rates. And then I was wondering how much, because we have like a 30, 40 minute slot, how much time should I spend? So I'm going to give you one nice, good, very important piece of literature that you must all look at. And that is how 3D has changed completely to become a first-line imaging technique in cost-effective evaluation of gynecologic pelvic disease, which is really the essence of figuring out what is going wrong. So this is something that is a free download that I would encourage all of you to read. And then we pretty much be realizing that, yes, things are going in the right direction, and how we can use images like this that you see here, such as some pregnancies with a septate uterus will actually carry on. But if you have a vascular septum, the chances of miscarriage are high, and that 2D will not differentiate between a bicorporeal uterus or a septate uterus. And we really need to have the 3D thing going. After all, the problem is not small. We know that 1 in 6 couples will have infertility. Treatments are getting more complex. They require more skill. They require more money. They require more time. And the optimal use of technology has emerged as something that is very important in increasing take-home baby rates. And then, therefore, we can manage our fail cycles much better in ART, and we can handle the entire problem more efficiently in terms of where should we invest our money to get the maximum result for our patients. And so that is what this talk is going to be about. So I'll take you through a few scenarios. And one is, ultrasound is a roadmap for fertility enhancing surgery, because we do know that some patients will benefit from fast tracking to surgery. Also, how ultrasound on day 2 or 3 of every treatment cycle is necessary to make sure that you don't get stuck in traffic jams later on in life, in that cycle. Also, every time a patient comes to you as a new patient, do an ultrasound then, or get an ultrasound done and see that, yes, these are potential problems, even if she's had hundreds of ultrasounds before. And we must realize that even as an office service, we must use new technology, because today new technology is cheaper than ever before. And any technology like an iPhone, for instance, becoming cheaper after 3 months and 6 months and a year, the same way ultrasound technology is now much cheaper than ever before. And then I'll take you through the fact and how we can use standard ovulation monitoring, the advantage of 3D and powered Doppler in routine folliculometry, a bit on the status of ultrasound in fallopian tube evaluation, how to therefore make some sensible purchasing decisions, and then doing one's own scans, but liberally working as part of the fertility team by radiology support as and when it suits you, but definitely on certain fixed days of the cycle to get more information. Now, this is the slide that I was mentioning then, and that, you know, technology hasn't helped us yet because we are just not on the same page, and therefore, first things first. We must tell the patient that yes, there's going to be a transvaginal scan and it is safe for you and it has tremendous advantages. I can see much better. The other thing is that from a infection point of view, don't leave it to somebody on the team who may not be the most trained person. You might leave it to your most senior nurse. The nurse might leave it to her most junior assistant. She has 1,000 other things to do. That is something we must avoid. Always start scanning at the introitus. We tend to introduce the instrument, right? And then start working when we're in the fornix. You might miss a lot of information. We like to use depth and magnification, which is very important when we're making ultrasound images, when we're making any radiology images, that's important. We must learn how to move the transducer liberally from left end to right end, from top to bottom and so on. And also remember that within the pelvis, you have other organs as well, that it's a shared space between the urinary system, between the rectum and the anal canal, between small bowel segments, between peritoneum. There's lymph nodes, there's vessels, there's the spine at the back, there's the pubic symphysis in front. All this can be there. Then you must realize that it's part of clinical examination because you can elicit fixity and you can show tenderness. So it's not just the image, but also like an extension of the clinical examination. And keep an open mind and you will get more information. So with that kind of a background, you then go ahead and do follicle monitoring. And remember that we no longer like to use hazy images like this. We turn the gain down, we get larger images. We scan from side to side and realize that this follicle actually is not the leading one. There is something here and we want to know what is this. And this turned out to be the leading follicle. Then you go back and say, why are there two follicles? I never gave this patient any medication. She says, oh, I forgot, I took the Letrose instead of the folic acid. And then you realize, oh my God, if I hadn't swept my transducer from side to side, I would have missed this completely. So these are technical things that are very important. Then of course, also how we measure a follicle. There is a nice round follicle, one measurement is enough. If you have a little ovoid follicle, two planes, but the moment you have anything and there's a discrepancy with the size that somebody saw yesterday or day before yesterday, then it's nice to do a mean of all three. And then you remember, you measure the inside of the follicle to the inside of the follicle. And then you look at the images, whether you're working like this. So that is very, very important. Also do remember that there are certain stages that you will never see in folliculogenesis, and that is the primordial follicle until it reaches this accelerated growth in the previous cycle. This is in the luteal phase of the previous cycle. When we come to this cycle itself, we know that these multiple small follicles will always be there up to 5 millimeters. And then one of them will get selected around day 10 and then go on to mature. And then it will have a nice flow around it. And that's how you tell that it's not an empty follicle. So then instantly we switch on power Doppler and we find the answer. So today we don't really like to work without power Doppler. So don't buy a machine that doesn't have power Doppler in it. And then of course you realize that it's all correlated with endocrinology. So there is a gonadotrophin independent growth which proceeds the follicle until it reaches, until about 5 millimeters. And you can find these size follicles in every ovary. Then when you have a fall in the FSH levels, which are somewhere between day 6 to 9 in a 28-day cycle, then the follicles with the lesser FSH receptors will go into atrophy or atresia as we like to call it. And then that's how you get a dominant follicle. And of course, in medicated cycles, you get codominant follicles. Then you realize that these grow at a rate of about 2 millimeters a day, the range being 1.5 to 2.3 until just before ovulation. And just before ovulation, you might grow between like 2 to 6 millimeters as well. And all of this then correlates with the amount of E2 levels. So a good follicle will be equivalent to about 150 to 400 picograms. And if you have multiple follicles, you divide the number of E2 readings. And then of course, you find this follicle suddenly jumps up. When you look at this follicle and you try and see it, sometimes you find too many follicles, you can count, or you can use 3D automation, which now is available very inexpensively, or send them off to a radiologist next door and say, okay, can you please assess this for us? Because there's just too many to count. And that's the best way to actually count multiple follicles. It helps you to make decisions on the possibilities of hyperstimulation, ovum freezing, and also HCG trigger versus an LH trigger and so on. So these become important things as we go along. When we want to see when is ovulation imminent, and this is particularly important for the IUI cycles, try and look for the cumulus. The more you look for it, the more you will see it. And it's a tiny echogenic focus sitting here about 1 to 3 millimeters, and it's seen in about half the number of follicles, and about half you don't see it. And if you don't see it, it does not mean that it's an empty follicle. We don't identify empty follicle these days by that way. We do it by power Doppler. And then, of course, you must realize that not all follicles will empty out and become small when there is an extrusion. And this is an artist's concept of extrusion, and you realize the follicle is actually, follicle fluid is oozing out. What we see on the ultrasound would be that the follicle becomes smaller and fills up with echoes. And sometimes there's so much hemorrhage or ooze into the follicle that it may not actually reduce in size. In that situation, you try and look for a small amount of fluid, and that is useful. And sometimes you can have a large amount of fluid, or you can develop a septation within the follicle. So all these are indirect signs. Like here is a large follicle with echoes and with septation, because truly speaking, this is the old follicular space, and this is the space between the follicle and the rest of the ovary. So these are things that you have to be aware of, and not just label people as unruptured follicles all the time. There may not be a collapse in the follicle at the time of extrusion. Now, we used to do a lot of corpus luteum studies before, and we used to think that the echogenicity of a follicle or a corpus luteum, or the size of a corpus luteum is useful, or that the flow velocity is useful, or the vascularization is useful. It is not. The best way to look at corpus luteum function is progesterone. So we don't really believe now in doing mid-luteal phase studies. They don't help us. We depend instead on a mid-luteal phase or mid-secretory phase progesterone, serum progesterone. And so this is the sort of workup we do. We always magnify, we make sure that we spend time doing an ultrasound scan. And that is why sometimes you need to send to someone who's a dedicated person who actually does radiology work, sonology work, and then say, okay, this is the kind of information we want to look at. And then, of course, we say, all right, what happens when we stimulate a cycle? When we stimulate a cycle, if you use the low dose letros, then you will get single follicular response. Otherwise, if you use clomiphene or use gonadotrophins, you will find multiple follicles, a higher growth velocity, which means not 2 millimeters a day, but actually between 3 to 4 to 6 millimeters a day, and 6 is usually too much, and we like to use a cutoff of 4. Also, before they become mature, they tend to achieve a larger follicle size. So whereas we normally consider an 18 millimeter follicle to be mature, in ART cycles, you often have follicles at 20 and 24 that are truly better quality follicles. So we keep that at the back of our mind when we plan to give the trigger. Now, in terms of hyperstimulation, then again, ultrasound can help you. And typically it is in the middle of the proliferative phase, around day 10 or so. If you suddenly have new follicles that appear, which are between 8 and 15, you know you can be in trouble. And then you start thinking on what to do with the cycle and how much more stimulation and how to prevent hyperstimulation, and whether it's HCG or LH, etc., etc. On an average, if you have more than 15 follicles per right and left ovary combined, that also predisposes to OHSS. And then there are some color parameters of a stromal PI, particularly of less than 0.75. And that's the best way to actually assess it, that you do look at the ovary, you switch on power Doppler, and you do a PI in that vessel. Then, like I said, automation has helped a lot, and this has now been brought down onto medium level machines as well. And you can share this work with a radiologist in case you don't have this. And this is one of the best functions that we like to do. We actually map out the entire number of follicles for you. We can tell you the actual mean diameter and the mean volume. Sometimes the volume is a better reflector of the quality of the follicle, and that's how it works. And then, of course, we're able to identify abnormal follicular genesis. And truly speaking, there are only 2 or 3 scenarios. One of them is atresia, when none of the follicles developed FSH receptors and suddenly they all collapsed. And you know that you then have to plan and make sure it's not a situation of LH excess, or that you weren't using spurious drugs, and that the stimulation was adequate. Then you have something which is called a follicular cyst formation. They exceed 26 millimeters. You did get a change in the endometrium, but no signs of ovulation, no clinical features, and the patient is not conceiving. Then you know you're looking at a follicular cyst. and the E2 levels don't correlate. And then you can have a follicle that just becomes static. And that is what we used to call the unruptured luteinized follicle. Now we realize that truly it's not even a follicle. It's just a cystic space that fills up in every cycle. So the best way to check these is to do a day 2 cycle. So we don't really make a lot of emphasis on the unruptured follicle anymore. We know it's a residual space, and we check that on day 2 of any cycle. And that's the best way to really exclude this diagnosis. And then always correlate follicular function with endometrial thickness and morphology. We know that in the menstrual phase, it's a thin endometrium. We know that the endometrium then becomes triple layered on the last day of menstruation and is typically somewhere 3 to 5 millimeters thick. We don't like it to be thicker than that. And then we know it becomes thicker, more juicier, and typically anything more than 9 millimeters is very good. And sometimes we manage with 7 millimeters as well, but beyond 9 is what you want. And in the secretory phase, the background of the 3 layers remains. But what we do is you find a lot of added echoes, and then you know that you're doing pretty good in terms of a secretory phase endometrium. So these are the cyclical changes, and they reflect the fact that the glands are growing, the endometrium is thickening, and that you truly have much more spiral arteries within there, and that the basal layer in each region of these glands really becomes far more full of particles. Now, one thing that we forget to look at in the mid-cycle is how receptive is an endometrium. And one, of course, is endometrial thickness and morphology, like I showed you, but also look for peristalsis. In the mid-cycle endometrium, you will find that the endometrium is not only thick, but nicely peristaltic. Not that the endometrium is truly going into peristalsis. This is the effect of the subendometrial myometrium. And what we find is that waves start from the cervix and go up. And not just random waves like this. Like here, you have a bit of a wave coming here, and it's all to and fro movement. So this is not nice. We need waves that start from below, go all the way up, and you typically would find that they come at about a 2-minute interval, and that's the right time then for your HCG administration. And if you don't find that wave, you know it's not the perfect time, or that your preparation of the endometrium is not a perfect endometrium and gives you what you need to do. So what we like to see is a wave starting here at the cervix, going up. Now this is peristalsis. Then this becomes narrower, and you can see the wave actually moving on, and it's moving towards the fundus, as you can see with my arrow, and you can see it moving higher and higher, and you can see that now it finally has reached almost the fundal area, and you will typically find waves like this every now and then, and it's easy to do. And that would then also tell you that, okay, how the next question to be answered after this is, when should I monitor the patient? Certainly baseline on day 2 or 3, depending on when you want to start stimulation. And then when should I do a follow-up? If it's a 28-day cycle, usually day 10. But if you look at the patient's previous records, duration of the cycle, and the medication, then you don't wait until 10. You might even start monitoring her again from day 7 or day 5, just to make sure that a cyst has collapsed and you want to start late treatment. Day 7 is often a good day for patients who don't respond the way you want to, or in case you want to add, say, injectables to clomiphene. And it really helps you to fine-tune the medication that you're going to be using, and then look at her file carefully and see where is things going wrong and how can I help this out. And this bit about a mid-luteal evaluation is something that we have now dropped. We don't talk about it at all anymore. The other thing is that every time you're doing a scan and you see something, just check that fixity. Did you see how much I'm pushing? I'm pushing and this ovary is not moving, and then I'm confirmed that yes, there is debris in this ovary. Both ovaries are stuck posteriorly, and then the patient complained of tenderness and fixity, and I knew I was looking at endometriosis, not a simple hemorrhage. So all this must go on every time you do an examination. Again here, something similar. And every time I push, it's tender. I wasn't sure what this was. That turned out to be a residual endometriotic cyst. And then you realize, yes, here is again something that is fixed and tender, and it's not just pure hemorrhage, it's endometriosis. So we keep our mind open at all times. Here again, I'm not sure whether it's a solid mass, a cystic mass. I move it and I find a lot of mobile debris. I know it's a fresh bleed in there. I know it's a liquid structure. And then of course, when you see something like this, you say, oh, I can even see the communication. And then I know that this is truly a hematosalpinx and not the ovary. And then you start looking for the ovary separately, and you find the ovary lying separately next to it. And so that's how you use ultrasound as a real-time examination to get a full diagnosis. Similarly, whenever you're looking at a lesion, again, we always run a power Doppler or a high definition Doppler as you see here, and then you realize, yes, what am I looking at? Is it vascular? Is it a corpus luteum with hemorrhage, or is it not? The best way to tell is with power Doppler. So we use our skills all the time. The clinical pushing, the clinical fixity, the clinical tenderness, the appearance on ultrasound, as well as power Doppler. And then you must realize that on that day 2 scan, you have to go through everything. Even if the patient has had hundreds of scans elsewhere, I always, but always insist that we must do a detailed scan at this first encounter in every cycle to improve outcomes and also to assert your profile, which means that I know that I need to solve my patient's problem and I will go about it systematically. No, that, oh, it's very inconvenient for you to come, or we're just recovering from COVID and don't come. No, we say that, look, I need to reassess your endometrium, your myometrium, the ovaries. I need to make sure someone's looked beyond all of this, the tubes, the peritoneum, lymph nodes, tuberculosis and stuff, and maybe run all the way up, or maybe even send it off to a radiologist to make sure that you do not only a pelvic scan, but also look for tuberculosis in the pleura, in the adrenal, in the liver, and so on. And that is how we then say, yes, this is the way we like to actually go about. So we always must do a day 2 scan, and that is important. And then this is also to decide that we will use ultrasound as a roadmap in case this patient has to be fast-tracked to fertility enhancing surgery. The idea is not to waste cycles, but the idea is also not to do surgery for the sake of doing surgery. So how can we help? Well, this is my typical example I like to start with, the broad fundus at laparoscopy. And this is that mention about how we can almost replace endoscopy, or at least facilitate it largely. I like to work as teams. So I believe that a broad fundus is usually adenomyosis, of course. And my 3D tells me I don't see the outlines carefully and I have stranding of the myometrium by endometrial thick strands all over. I know this is severe adenomyosis. That's my first diagnosis. It could also very well be this, which was a fibroid sitting inside a septum and a broad fundus. Or it could be one canal, which is actually a unicorporeal or a uniconnovate one, and in the rudimentary horn, which is non-canalized, I find a fibroid, again a broad fundus. Or it could be a large fibroid without a cavity component, pushing the entire cavity to one side, and a large fibroid like this. Now this fibroid is important for me because if I get an implantation and my placenta doesn't reach across, then it's the same as losing a pregnancy. So then this fibroid in a patient with failed IVFs or not being able to conceive, or with a previous miscarriage or with a previous IUD, I would like to remove this fibroid. So I want to map this out, and for that I must have a coronal view and I must do a 3D. So you must fast track these patients to good 3D and then to fast surgery, or like a broad fundus like this. 2 fibroids and not 1. I might laparoscopically remove this one, forget about this one, presuming that I enucleated this one. And yet this was interfering and acting like a valve right inside my cavity. So I should have removed this one hysteroscopically, facilitated this one laparoscopically, and monitored the whole process. So this is how I say we should be using ultrasound and working together for the best outcome. Because in fibroids, we do know that there are 2 aspects, those with the cavity component and those that are in the wall. When we have an odd fibroid here and there, you can tell even on 2D. But look at this combination. Many fibroids, I don't really see an endometrium. One sitting on the intramural area here, one here, distorting the tubal axis. This one, which will never let my embryo transfer catheter pass through comfortably. Then this one sitting in the wall. But I know that she had one failed IVF before, and she's also had 1 late miscarriage, 23 weeks if we never found out. But then it could have been this poor implantation because the placenta could not build itself here. And therefore you need to be careful and give this information. Not all fibroids need to be removed, but they need to be put into perspective. We now also rescored. We used to use a Wamstecker classification for fibroids and say, are they in the cavity? Are they out of the cavity? Are they less than 50% in the cavity? Now we say, no, we look more. We do 3D and we say, okay, the size, the topography, the extent of the base, the penetration into the wall, and whether they're on the lateral wall or not. And we give them a score, and that guides the endoscopic surgeon on what is the kind of process we need to do. If it's a score of 0 to 4, I can manage with a nice office myomectomy also. But if it's 5 to 6, then I know that I need to work harder and then either use a 2-stage procedure or a GnRH analog or whatever you prefer. Some people like to use ulipristal. I find that most of the time when I've looked at surgery and shared with my colleagues, and I've gone in and looked at these on ulipristal, they're so yucky on removal that I'd rather use my old-fashioned GnRH analog, etc., etc. And of course, if you get a score of 7 to 9, then you have to have a non-hysteroscopic technique. And that's very, very important. The same thing for all the wall fibroids. We use a FIGO classification then and mention where it's located, how many are located, and then of course, how much is within the wall and how much outside. So we plan our endoscopy and make sure that the endoscopy will be successful as much as possible. And then also the etiology. 3 different cases, each with a poorly defined endometrium, each with a poorly defined posterior wall lesion, partly in the cavity and partly outside. This one is peripheral flow. This is a fibroid. I might look into a history before I decide to do anything about it, because after all, there's hardly any component there. This one has a spoke wheel configuration. This is an adenomyomatous lesion and will interfere with implantation. I must do something about this before I plan an IVF. And this one is actually an arteriovenous malformation. If I try her out with a hysteroscopic resection, I'm going to have pools and pools of blood pouring out. I can't afford that. I have my guide. I know what to do. I might arrange blood, or I might try and make sure that this goes down with a GnRH or even 3 months of the OCP, and then make a decision. So this is how we go step by step by step and take decisions. Or the fact that there might be more than one lesion. Like this one here. One large polyp, one small polyp. This one here is polyp inside a unicornuate, unicorporeal uterus, or hemiuterus as we like to call it now. This one, when I'm not sure on what's going on, is it just inhomogeneous? What do I do? I realize, no, this is a very vascular polyp, and I can see the outlines and I can see a leading vessel going into it. Or multiple leading vessels like this. And when I see multiple leading vessels in a leash, with one vessel dividing into 3 instead of just giving off one side branch, I start looking at malignancy. And sure enough, this was a malignant polyp. And then the whole outlook changes in the whole pregnancy. So this is how we like to look at lesions, by using technology as much as possible. Or a hypoechoic focal lesion, which I then know is like a fibroid polyp. So I keep using my image morphology to guide the best outcome in that particular patient. And here again, multiple polyps, you map them out, and you start resecting them as you go along, not forgetting that there's some teeny weeny ones sitting in the fundus as well. So you know it's going to be a longer procedure. You warn your anesthetist, you decide what you're going to use to distend the cavity, you decide how much glycine you'd like to do. All these things just go on, and then you say, okay, because that one was vascular, it might bleed more, I should be ready for a procedure like that. Or tell the patient, look, if there's too much bleeding, I might just wait, and we might do it as a 2-step procedure. It really helps you in counseling. And then things like this, a T-shaped uterus. We always believe that this limb is longer, and this limb is much longer, and the horizontal extent is less. So I want to create space. I want to do a lateral metroplasty. Very nice. But if I have a uterus like this, scarred by endometriosis, T-shaped canal, but my scarring is extended beyond my endometrium and into the myometrium, the moment I try to resect some myometrium here and do a lateral metroplasty, I'm going to get momentum into my instruments. I'm going to perforate that uterus. I don't want that to happen. And so what I do, I map out the whole uterus before I actually begin, or I get mapped out by my colleague, and that is how I like to do it. And that's how we do it. So that is to enhance patients with pathology, like Mullerian abnormalities, like all of this, and then we take it on from there. And then what about day 2? What do I do on day 2? I exclude residual cystic areas. I assess pelvic pathology, like I said, even if it's been done before. I look at the uterine cavity configuration, and I do an antral follicle count. And let's look at how we do each one of these. So when I'm looking at residual cystic areas, I know that some of them will require more gonadotrophins, and they may enlarge with ovarian stimulation and twist during my pregnancy. Why should I do that? I may as well then either aspirate this, or better still, look at it if it persists for a few cycles and you're doing, just remove it laparoscopically and get it all out of the way. Why should I use kilos and kilos and thousands of gonadotrophin to achieve the same result. Then, of course, what do I do with an antral follicle count? I do it manually if there are a few follicles, and if it's not, then I say, okay. And then I count them on the right, I count them on the left, and I like to say, look, I need 5. And then I'm going to talk to this patient. And if I have an extensive count, I can sometimes do a manual count, but if it's too extensive, then again, I happily go into my automated count. And I know that although the age of the patient remains the best indication of what is going to be happening, the AMH is a good indicator, but the antral follicle count is far more practical, because what is the problem with AMH? A, expensive. B, different bioassays, different assays, and different labs have different results. And it's different on different days of the cycle. So I get very stuck. So the antral follicle count is repeatable, very nice. And my second indication is ovarian volume. So on my day 2 scan, I will always do an ovarian volume and an antral follicle count and exclude residual cysts. I will then go on to looking at the ovary in all my PCOs to see how hyperemic is the stroma. And if it is, then I know that my downregulation is inadequate. I like to see a completely avascular stroma to start with. And then I know I have downregulated correctly. Otherwise, I will go back and do one more cycle of downregulation. Then we move on to what do we do for my rapid evaluation when my patient first comes to me. Do an ultrasound scan. It's an extension of the clinical evaluation. Get it done from your neighbor if you don't have your own good machine. But it makes a huge number of decisions right there and then. Because you want to look at Mullerian abnormalities, and the 2 important ones are the septate uterus, most importantly, and then from a prognosis of pregnancy point of view, you want to make sure it's not a bicorporeal or a heavy uterus, that you have to be careful about that. Then you like to look at fibroids, polyps, the presence of tubercular disease, adenomyosis, and adnexal disease. And therefore, you will then do this correctly. So then I use my cavity evaluation very carefully, and I don't use the old software. This software is available free of cost. No, I will invest in a slightly better machine, which then tells me with this rendering engine that there is an endometrium, that there is an endometrial myometrial junction, that there is no adenomyosis, that we have a good myometrium beyond that. And I know from my new software, not so new now, this is 10 years old, and again, on almost all machines, depending on which vendor you choose, you cut through, because it's not a standard curve, it's a curve, and then you'll be able to see the cavity much better. So I use software all the time to tell you about that, and then you decide what to do with the cavity. So we don't use the old rendering engines like this, which said, oh, 1 synechia. No. We say, yes, normal uterus. Another case here, thick synechy just beyond the cervicouterine isthmus. I cannot negotiate these when I do my embryo transfer. Amputation of both cornu, and I know this is inflammatory disease, and I must start looking for inflammation sitting there. Or a largely obliterated cavity, and you start saying, oh my God, should I actually consider doing a synechiectomy, or does the patient want to fast track to surrogacy? When you see something like this, you will obviously then encourage a fast tracking to surrogacy. And when you see something like this, a vertical course of the interstitial part of the fallopian tube, I say, this rings my bell. This is tuberculosis very likely. It correlates on studies that we have done. And combined with the presence of synechy here just beyond the cervicouterine isthmus, I will then investigate this patient for tuberculosis because I have a clue in the vertical extent. The tube should have gone in a horizontal direction, just as you see here. It should be in a horizontal direction. And that is how I use ultrasound on the first visit of this patient. For adenomyosis also, a slightly thick wall posteriorly can be a good clue. But what I now use routinely is 3D. It tells me that the myometrial junction in this normal case is what it should have looked like. Here you have all this stranding. Here one wall is spared, but the fundal aspect and the right wall are bad. And here you have extensive obliteration of the cavity. You know that this is a bad uterus. You say, okay, I might try IVF for you, but if it doesn't succeed in the 1 or 2 or 3 cycles, I think we should move you on to surrogacy. Or in case you have limited times and limited means, then maybe a surrogacy is a better option. So it helps you to give your patient all the reproductive options that you can possibly give her. And then, of course, don't forget the simple things. Look at that time of your cycle, whether there's a nice secretory endometrium if she's in the secretory phase of the cycle, or a good mid-cycle endometrium if that's the phase that she is, and so on. Also remember that less than 9 millimeters may not give you good results. And some people have shifted this to 7 millimeters, but the fact remains that 7 does not work as well as between 9, 10, 11, and 12 works. Now, one great thing important to realize if you don't find a good endometrium is look at whether your follicle is good quality. Look at the follicle. When it reaches about 18 millimeters, it should be nicely vascularized. If you have vascularization like this and you have a thin endometrium, then start thinking of a tubercular endometritis or a previously treated endometritis, or has she had a repeated curettage that has wiped out this endometrium? Is it a clomiphene cycle because of the anti-estrogenic activity of clomiphene? Does she have prolonged exposure to OCPs in the last few months? Or is she one of those rare systemic lupus erythematosus, etc., vasculitis kind of a picture, rheumatoid arthritis, and do I need to look further? And that is how we confirm that. And then, of course, you have lots of options. We won't discuss those today, but we really know that there is just so much available today to treat the thin endometrium. Also, that you should be aware that your patient will immediately say, oh, thin endometrium, I can manage it myself with the internet. And they give you these stupid names. And if you know these names, then you're happy, because then you can throw it right back at them and say, no, I don't believe in my donkey root or your rose hips. Maybe you can try wild yam. That will fix them and put them where they deserve to be. After all, we know that even though we used to use large doses of all this other stuff, it doesn't work. What works is a scientific analysis on the ultrasound of tuberculosis and no tuberculosis. And do I fast track my patient to another possibility? Remember that just simple calcification is a great indicator of tuberculosis. So even if you find one dot, thin or thick, in a thin or a thick endometrium, and if you find a little bit of fluid at the wrong time of the cycle, mid-proliferative phase, day 10, fluid should not be there. Tuberculosis. Don't start off treatment on the basis of this, no. But find clues that will tell you that yes. Because we did this many years ago. And we said that there are certain signs that are always seen in tuberculosis. And let's see what these are. One is that if you find that there's a cyst in the myometrium, which instead of showing the normal vascularity like this, as you find in adenomyosis, is avascular, you start thinking of tuberculosis. The vertical extent of the tube I already showed you. Or if you find a follicle is echogenic in its outline. This is a hypoxic follicle, just as you find in ovarian torsion. We know that tuberculosis is a disease of hypoxia. That's where mycobacterium multiplies, where there's less oxygen. And so then you will say, oh yes, of course, this is what I heard. Let me evaluate this patient laparoscopically as soon as possible, look for tubercular disease of the peritoneum and treat her. And then of course, if you find that you find tubal fluid with endometrial fluid in the middle of the secretory phase, it just fills up. Then you know that yes, again, tuberculosis. So these were 4 very important findings that we had published 7 years ago and have now been accepted all over the world. Now, do remember that we keep thinking a good scanning is expensive. That's not so anymore. Technology has become cheaper and cheaper. And instead of crowding ourselves with some investigation at some time, go systematically. Don't pick up an old transducer that doesn't give you a good frequency on the transvaginal view. Same patient, same day. Poorly defined endometrium. I wasn't sure what it was. I said, let me take another look with the same with a better transducer. I defined a polyp. Poorly defined posterior wall. I picked up my 12 megahertz transducer and I found a fibroid sitting at the back. And then you found that yes, when I evaluated with 3D, this cavity wasn't as beautiful as this triple layer looks. It was actually not just the polyp, but some other lesions as well, and a very trimmed off cavity. Then I knew I was looking at tuberculosis plus fibroids plus polyp. I knew I have to start this patient properly, start from scratch, hysteroscopy, laparoscopy, full evaluation, and so on, and then move on. So that is how we now look at things. So we go beyond, and then we also try and occasionally dabble with MRI. The problem with the MRI is it's more expensive, takes more time. Radiologists don't like to work on these. And the software is very cumbersome. 3D is easy. New software comes, you press one button, you get a nice display by turning one switch called silhouette. I can now tell you exactly how many fibroids. And you tell this patient, look, I have to remove this many fibroids. If you want, I can remove it. Or you want to take a chance, you try on yourself for 3 months because you're young, or you're 42 years old, would you like to fast track to surrogacy? These are then scientific decisions that you make on behalf of your patient. So I just like to use these all the time. I use a lot of power Doppler and we use a lot of 3D power Doppler as well. And then we also have ways where in some patients, because of disease, you don't see things very well. And we use a 3D technique called BCI, where I see the outlines better and I'm able to identify each polyp for you. So very often we work together. That means the gynecologist rings me up and says, I see very fuzzy endometrium. What is going on there? And I say, no, send them over. I will do a BCI and let you know what is going on. And then you investigate further. Sometimes we inject a little bit of fluid during ultrasound and combine it with 3D, and that will tell us more about polyps. It will tell us more about cavity outline, and it might even outline additional polyps for you. So we do a lot of this, and we don't think twice, should we do it, should we not do it? No, put a little bit of fluid. We use an embryo transfer catheter. It's the best to throw in fluid or an infant feeding tube. It takes 2 minutes and we get answers. MRI, like I said, very cumbersome, but I still like to use it occasionally for very large masses where I'm not able to see the uterus properly and I'm not sure. Also, sometimes in the Adlexa, we have a difficulty differentiating between blood in an endometriotic cyst or whether it is mature cystic teratoma. There, we are able to pick up the fat in the teratoma and blood in the endometriotic cyst, and therefore it becomes easy then to sort that out. But that is perhaps the only indication for MRI. The usual indication for MRI is a badly done ultrasound scan. That is something we must learn to accept. Then, of course, we remember that, yes, laparoscopy is the gold standard. Also remember that ultrasound does miss a lot of peritoneal disease, but it is the first in the diagnostic cascade. A well-done ultrasound will guide you exactly on what you should be doing. And also remember that I've shown you now that even in folliculometry, you must do at least a power Doppler, and when there are too many follicles, you use 3D all the time. And then endometrial volume. You find when you look that some parts of the endometrium are thicker and some are thinner. And you reconstruct in 3D and you say, oh my God, what an ugly looking endometrium and uterus compared to this. And the prognosis changes. This tube is whacked off completely. This one, distorted tube. There's hardly any endometrium left. And I have synecdoche sitting right beyond the cervicouterine isthmus. Bad news. But you're able to break the bad news to your patient and say, look, I'll try with a hysteroscopy. I'm not promising you. And then we'll see what we can do next. Endometrium volume. Better than endometrial thickness. We know that you can get a very juicy endometrium and yet sometimes you find the patient doesn't conceive. We do a 3D called vocal, draw all around it, takes about 1.5 minutes, and we talk in terms of volume. If the volume is too little, below 1.59 ml in my mid-cycle, I say yes, it will not implant. And I use it all the time for adenomyosis, for anomalous uteruses in terms of Mullerian abnormalities, and also when we have intrauterine adhesions, synecdoche, etc. So we use endometrium volume when we find that a good endometrium does not implant. And we just also can tell how much is scarred endometrium. So we draw only around the portion of active endometrium. And then that sometimes becomes much better than just measuring endometrial thickness. So this is the way we now use technology to give you the answers. We also use simple technology. How much vascularization into the endometrium on my day of follicle size 18 when I'm giving my ECG. All of this IVF stuff we do on day of follicle size 18. And here I find not enough vascularization. Here I find excellent vascularization. This endometrium looks thick, no good. This endometrium looks thick, well vascularized. My patient will implant. I know she will. She doesn't have an endometrial factor. And then, of course, we use power Doppler, not color Doppler, because it can tell flow in all directions. And never ever go ahead with equipment that doesn't have power Doppler. The settings are important. That's something that's pure technology, and I like to teach in the workshop. So we'll skip that for now, but remember that settings are very, very important. This is what I was talking about, the imaging of the endometrium. We also do a 3D of the power Doppler of the endometrium, because this is something, again, that we published 10 years ago. And we realized that we can find 3D indices that we tell you about. And if we find that it's not following this nice cyclical change, and then we must not transfer in that cycle. So in mid-cycle, if my vascularization index is less than 1.0, or my flow index is less than 31, or my VFA is less than 0.25, then I will not use that cycle for an embryo transfer. I will prepare that patient again. So few things emerging already. First visit, good high-tech ultrasound. Day 2, good high-tech ultrasound. mid-cycle, good high-tech ultrasound. And you will always have answers. Again, the peristalsis I was telling you about. And then, of course, also the quality of follicles. We do like to look at how vascularized these follicles are, and they give us better implantation rates. We also like to look at uterine artery Doppler. And again, this is done in mid-cycle. And during our vaginal scan, we put this as close to the cervical uterine isthmus and see what is the PI. If the PI is more than 3.019 on the day of the HCG administration that you were planning, then I'm not going to implant. So that's not worth it. And we always look at the worst PI out of the uterine arteries, and that works out well. So if you have a decent one on one side, may not be so good, look at the worst one, and that works. We look at follicular, perifollicular vascularization also. The ones that have better, the good follicles will all have more vascularization. Again, a very good index on whether my follicle quality is decent. So then you will say, yes, I'm now going to have a nice outline. And remember that all of these don't apply to natural cycles. They apply to IVF cycles, which is follicle size 18 and beyond. And of course, confirming that it's a good follicle, because that will be confirmed by powered Doppler. Now, for the fallopian tube, I'll spend just a few minutes more before we finish. Morphology, very important. We know by examining that there's a tubovarian mass. I want to know how much tubal, how much ovarian, how much hydrosalpinx. 3D tells me retort shaped, beak. This is the hydrosalpinx. This is the unhealthy ovary. I can't tell you whether it's endometriosis or tuberculosis, but I can tell you it's hydrosalpinx plus unhealthy ovary. Fast track this to a laproscopy, get a tissue diagnosis, and you get your answer. Then this particular appearance again. On 3D, very classical appearance. On 2D, I wasn't sure whether it's peritoneal loculus or hydrosalpinx. 3D tells me, don't worry about the loculi. It's all multilocular hydrosalpinx and an unhealthy cystic ovary hypoechoic. Again, fast track. And that's how we look at it. And again, organ relationships. The more we do 3D, the more we realize we can tell you on how to get the best results for your patients. And we always use technology. We always use technology, and sometimes we go on to a 12 megahertz transducer instead of the standard 9 to 12. Some vendors will sell you 3 to 5 megahertz or 5 to 7 megahertz. That's not good enough. 5 to 9 is the minimum you should pick up, and then look for this. For tests for patency, HSG still has a role. Laproscopy, gold standard. We now have many commercial preparations, but I do not believe that any of these is effective enough for me to depend upon. So I do not like to use ultrasound procedures as a guidance to tubal patency. I still believe that it's either an HSG at the basic level, or you just move on straight to a laparoscopic visualization. Because all these fancy procedures are very good, but they don't actually work. Then the most important thing, that we work as a team, that we know that we have to overcome dilemmas. We know that 2D is not good enough. We know that we have to tell the difference between a uterus that is septate or not. 2D will not help us, except sometimes the transverse dimension is bigger. Do a 3D with the radiologist, tell him or her, and they will show you a septum, and then you move on. Or a nice hemiuterus, unicornuate as we used to call it, single horn. You know the prognosis, that we might get you pregnant, but you might miscarry early. Are you sure you want to go through all of this? You might need a cerclage. Are you sure you want to go through all of this? So that is how we facilitate 2 cavities. This one, septate, deep septum. This one, you start looking, and you realize, again, septum, but again, a little fibroid sitting over there, right in the middle of that septum. And then, of course, like I keep saying, MRI is useful for these things, but the software utilization is much better with ultrasound. We have this fancy classification that we've dropped now. We moved on to the Esri classification, and we tried to simplify it, but it didn't work. We use the classical one, and we can tell you, but the most important one we've come up with is this one, which is a uterus which has the bicornuate, which you now call the bicorporeal, but there's a lot of myometrium sitting there, and this acts like a septum. So this is the bicorporeal septate uterus that will benefit from a hysteroscopic treatment so that you can get quicker results. It often is as bad as your classical septate uterus. And then remember that we now call this the dysmorphic uterus because it's T-shaped, and that is important. And then when we assess The degree of bicornualness, we always see how much is the indentation. Again here, we might have these cavities come together. I do an endometrial volume assessment in the middle of the cycle. Not enough. I request the endoscopic surgeon, please remove this. We need more endometrium here for implantation. So that is what happens. We've changed the classification around, and we would perhaps talk one day in detail on this topic. But essentially, what we do is to be able to identify the septate uterus, which is important for you and me to figure out. We also say how much is the septum compared to the cavity. The longer the septum and the smaller the cavity, the worse the prognosis. And of course, the more vascular septum, the greater the chances of a miscarriage. So that is how we talk in terms of a septate uterus. After all, not that it interferes with implantation, no, but it doesn't let you carry the pregnancy to full time, which is as important for someone who's working with infertility. So what we have to do is to open our mind to newer developments, to overcome failed cycles and improve take-home baby rates. But do remember, importantly, there is one treatment that needs treatment, and that's tuberculosis, and a normal ultrasound does not exclude tuberculosis. You can have a perfectly good endometrium, cavity, follicles, no hydrosalpinx, and the patient has tuberculosis. So please keep your mind open. A normal ultrasound scan does not exclude tubercular disease. Some are frank. You find all the findings I told you, irregular endometrium, echogenic follicle, and all that's easy to handle. But keep your mind open, work with someone who's interested in this, and then things will work out right. And thank you so much for your attention.
Thank you, sir. Can we have that Ashley slide which you skipped, sir?
The Ashley slide, which I skipped, of course we can have the Ashley slide. Just bear with me as I go back. And I love that slide. I like putting them all onto a single nice, wonderful plane so that we can, this is the one you were talking about.
Actually, sir, one more.
The American fertility slide?
Last fourth or fifth slide, sir, which you skipped.
Oh, this one.
Yes, sir.
Ah, the changes, is it? Or were you referring to, no, I think you were referring to this one. How we measure endometrial, this is the one I skipped.
One before that, so how do we measure the size, cavity and the...
This one, all right. Yeah. So, you see, normally what we do is, in a septate uterus, we draw one line here, in the intercornual plane, like so, interosteal plane. We draw a vertical up here.
Right, sir.
Yes. Tell me about myometrial thickness. And I draw from that middle line, I draw another line from the middle here to the top of the septum. Right, and if this much of the septum or the indentation is more than half of the myometrial thickness, I then call it a septate uterus. We no longer have an arcuate uterus. Yes. So with the arcuate uterus, what we do is, we throw it out of the window. We just see whether this dip, we don't go by millimeters, we don't say 5 millimeters arcuate, we don't say 10 millimeters septate. No, we say this dip is more than half of the myometrial thickness. This is likely to be a significant septum. We assess it in color in the mid-cycle. Is it vascular? Is it in the mid-proliferative phase? Is it vascular or not? And we give a prognosis. This is the other one we like to measure. That when I draw a line here and I find that I have my bicorporeal or bicornuate uterus, and yet between my interosteal line and the dip, I find a large amount of myometrial tissue. I measure this again and I compare it with myometrial thickness, which I measure from here. And then I say, okay, this again is a surgical situation. This again is a surgical. That is how we assess it. Yeah.
Thank you, sir. Thank you, sir. It was such a brilliant talk. It should have gone for ever and ever and ever. We just don't want to stop, sir. There are no words to express, and you justified the topic so well. It was like Bible of infertility, where we are not only getting ultrasound findings, but the infertility management. Roadmap for all of us, sir. And we are really thankful to you for sparing your valuable time. We know how busy your schedule is, but still you save time for us. And over to, thank you, sir. Over to Dr. Poonam, Varma, Shivkumar, ma'am. And one person for whom our success was her happiness, and we had the best time with her. Over to Dr. Poonam Varma.
Seema, can I ask one question?
Yes, ma'am, definitely.
Ashok sir, thank you so much for a wonderful talk. I think it really refreshed all our infertility practice. A few questions that I really want to ask you.
Yeah.
One is, sometimes the patient has a history of a late trimester abortion, and then we find a calcification with irregular endometrium. And you just now mentioned that calcification is a very important sign of a tuberculosis. So is there any way out where we can differentiate? Because I've seen some patients where it was a history of, they did not give the history of abortions earlier, and then we tried to find out the history. Then they gave, yes, we did. I had undergone an abortion at 13 weeks or something like that.
Yeah.
And
Yeah.
there were the bony chips, the chips of the bone were found in the endometrium embedded. So is there any way out where we can differentiate whether this is a bone or it's a calcification of the tubercular endometrium? Is there any way out where we can differentiate, sir?
No, not on the ultrasound morphology. We cannot tell the difference between a leftover bone or even a post-abortal endometritis, which then gets what we call a calcification. So
Okay,
that becomes very, very important to realize that the morphology of the calcification will not teach us about etiology.
Okay, sir. So the second question that I really want to ask is about the corpus luteum, that you mentioned that this that the vascularity of the corpus luteum doesn't reflect that it is functioning well. Yes. I just want to ask about, sometimes the patients of threatened miscarriage, earlier bleeding or spotting, they present with a bleeding in early pregnancy, and we do see there is no corpus luteum in either of the ovaries. So it's not about the vascularity, but there is absence of corpus luteum in either of the ovaries. So does that reflect that in such patients you should start heavy doses of progesterone, maybe a supportive progesterone therapy?
Well, then the first thing I doubt is that I like to be careful about the technique, that I must sweep from side to side. The corpus luteum might be sitting far away. I also know that a corpus luteum with hemorrhage can be completely isoechoic, the same texture as the rest of the ovary. So I always switch on power to see it's one of those situations. And then you realize that almost 90% get covered in that itself. But really the best indicator is still a serum progesterone. Yes.
Okay. Thank you so much, sir. Thank you. Now, Dr. Poonam, you can take over the questions.
Thank you. You have to unmute yourself, Dr. Poonam. Dr. Poonam, you're not unmuted yourself. Yeah.
Yeah. So, Dr. Ashok Khurana, thank you so much for. It's echoing. Just a second. It's echoing. Just a second. It's echoing. Just a second. Yeah, Dr. Khurana, thank you so much for such an informative lecture. I would say that we all are so impressed. There are certain take-home messages, what you have said. One was a very important thing that you see, by doing these kind of sonography, the treatment becomes really, really cost effective. And if you give them baby in the first cycle itself, it's not only the patient who gets more, but even the doctor gets more popularity. So that was one thing which was very impressive. Second was that you said that patient counseling is very important. Why? Because these 3D sonography and 4D sonography has really changed the world now, and especially the infertility world. So the way you have described, the way you have asked to use, the power Doppler for folliculometry, that's something really, really amazing. Your probe physics and the technical consideration while doing a small procedure like folliculometry, with your such vast experience, has explained it so beautifully, how important it is to measure the follicle, and how do you measure the follicle, when do you take single diameter, when do you take 2 diameters. So that's really very impressive, sir. A very informative thing what we have understood was the peristalsis, where you measure subendometrial, myometrium, and you look for 3 contractions. And then you think of, utilizing that cycle by giving the HCG. That was really, really extraordinary, sir. Then, of course, the full evaluation by using real-time examination, and of course, when to do surgery, unnecessarily why one should interfere doing hysteroscopy and laproscopy. That was something very interesting, sir. Also, the LASMA's score, which, you know, none of us, very few of us probably know, that LASMA's score has come up very recently and it's really being utilized for. Do you want us to take the questions now, Seema, or maybe after the panel?
Maybe 2 or 3 questions you can take now, and after panel we can take the rest. Maybe 2 questions from the
Okay.
panel, from the audience.
So there's one question by Dr. Deepa, that is it compulsory to do TVS on day 2 or day 3 only? And can we do it on day 5 during irregular cycle for baseline scan? So sir, we know from you.
Yeah, so basically the scan is to be done on a day when you plan to start treatment. So if I'm just making some baseline observations and I need it for a diagnosis, I could easily do it on day 5. But since most fertility treatments start on day 2 or day 3, I do a transvaginal scan on day 2 or day 3. I don't wait until day 5. But if you're not doing any treatment and you want baseline, you can as well do it on day 2, 3, 4, or 5. And of course, even during menstruation, you can very well do a transvaginal scan. Just put a Macintosh.
The other question by Dr. Arun Kumar Singh is that do all the septum need resection, or what size of septum needs resection?
So you see, we know that if we look at a septum, a lot of patients will carry to term without even knowing they had a septum, or they will conceive without any problems. And then if we look at the data that we used to hear, say 5 or 10 years ago, all these countries in Europe used to say, come back to me after your 3rd miscarriage. Americans used to say, come back to me after your 3rd miscarriage. Can you imagine a working girl? She gets married at the age of 29, decides to make a career until the age of 33, and then you tell her, have 3 miscarriages, come back to me when you're 37 and a half. It makes no sense. So then we started looking at this data critically. A septate uterus can do 2 things: failure of implantation, and of course, early miscarriages and premature deliveries. So then I need my criteria. If I find that the length of the septum is longer than the length of the residual cavity, you can fast track that patient, apart from the fact that she's had 2 miscarriages. If she has not had 2 miscarriages, when would I think in terms of a surgery? The second thing is the volume of the residual endometrium, the volume of the endometrium in the mid-cycle. That means my follicles reached size 18. I have like a 7-8 millimeter thick endometrium, 9 also. But is this septum going to interfere? I do a volume of the entire quantity of endometrium, and is that small or not? That gives me one answer. My third answer comes from vascularity. The septum will be vascular during menstruation and in the mid-cycle. But if I find vascularity on day 10 of a 28-day cycle, then I know that that septum will act as a pacemaker, and that activity within the myometrium will commence from that, go to the fundus, and then come down towards the cervix, so that the whole uterine cavity gets milked out, the entire embryo gets pushed out. So I always look for vascularity on day 10 of the cycle, and if I find a vascular septum, definitely that is a septum that would benefit from resection. So there's actually guidelines from ultrasound that can help you on which patient to fast track.
Excellent, sir. Excellent.
The last question at this moment, because we are running short of time, by Dr. Arti Luthra. Sometimes AMH is below 1, but AFC is good and ovaries show normally growing follicles. Should we keep trying for natural ways of conception in these cases?
Absolutely. We do understand that the AMH assay is a very tricky assay. We do understand that there are various brands on the market. We do understand that any sort of treatment in the past 3 cycles can alter the AMH levels. And we do understand that labs make lots of errors in AMH estimation, and also the day of the cycle. So I always give it a fair chance. If I see decent follicles and they're more than 5, we give it a very fair chance. You discuss it with the patient that, look, may not be perfect, but if you want to give it a try, it's worth giving a try. And I feel these will be all right.
Thank you, Dr. Khurana. Thank you so much. And over to you, Seema.
Thank you, ma'am. And so actually the answers are so good that we want to finish all the questions in the end. And now I would like to invite Dr. Nirmala Sharma to thank sir for the most relevant talk that we all have received. It was so beneficial. Like I can still feel, the vibes of this talk, this wonderful talk. Over to you, Dr. Nirmala. Dr. Nirmala Sharma. Dr. Nirmala.
Hello.
Yes.
Hello.
Hello. Yes, Dr. Nirmala. Yes, you're audible.
Yeah. Sir, it was, I like to thank Dr. Ashok Khurana for such a lucid and informative lecture. He has, in a nutshell, given everything, the A, B, C of doing an ultrasound, even to a newcomer who is just fresh out of the college, and those who are like us, who are practicing for so many years. Still, also, we can get so much information from him. Sir, I like to give advices also for my all colleagues also, my students also. What all things do we need to see when we are going to buy a new ultrasound machine for our setups? So I like to ask this question to sir. What all things to see? Because all different companies, whenever we need to buy an ultrasound, they only show us all good things, and they don't give us the key points which is most necessary. Then after people buy, then they know that this is not there and this is not there. So I like sir to just give last minute things that we all need to look when you need to buy a new nice ultrasound machine.
True.
Yeah. So that's a very simple answer actually. First of all, you look at your budget, and then
that is right.
And then you look at your
minimum. That is budget is right, sir. Except,
and the first thing you decide is that, do I need to buy a machine that's going to tell me heartbeat or no heartbeat? Brief, is it breech or cephalic at the end? Those are simple things. You buy a machine for your thing. Then you try and see how close is a good radiology center next to you. Is it next door? Then don't waste money. Then you use that person, let him spend his money, because technology is expensive. And you tell them to buy a good machine. But if you want everything in-house, which patients expect today, and if you want a good radiologist to come and devote a few hours there and get attracted to your machine, and then also do your anomaly scans for you, then we need to make sure that we have a good transabdominal transducer as well, so that you can pick up anything all the way up, which is not expensive at all and is part of the basic machine. But you must buy one that is between 1 and 6 megahertz, so that you can handle obese patients very easily.
Okay.
So that'd be useful for your pregnancies as well. The next thing is your choice of vaginal transducer. Make sure that you have at least a 5 to 9 megahertz.
Okay,
and,
fine.
And that would be at a lower cost. It's not so expensive as the 6 to 12. Then you must have at least power Doppler.
Okay.
That is an important part. And now you realize that there are a lot of vendors who actually have 3D, including what I have shown.
Yeah.
1/10 the cost it used to be, say, 3 years ago.
Fine.
So they must have that on their transvaginal transducer as well. Okay, and you can get such machines from anywhere between 14 and 25 lakhs, depending on
22.
So that 14.5 is really good. And then you have the bargaining power also. You see, I might buy my second one. And so what you do is, you give me a 3-year warranty on this, including all my probes. And that actually pays off for a lot of money. So that's the way you go about buying a machine. Yes.
Okay. Thank you, sir, for such a nice and such a informative lectures. You have really touched every aspect, and it has helped me to, your lecture has helped me to see certain points in my laparoscopy also now. Now I look for all these things while planning for laparoscopy also. Today I got such nice small key points which I must have missed so many cases before so many years. Thanks you very much. Thank you. Thanks a lot.
So nice to see you again.
Okay.
Sir, this is like you are putting everybody in.
I like to thank Seema also for such a long time. I was so academically, I was so fine for many years, and since 2-3 years I am not into academics, but now I realize that I need to go back again for all these things. I thank Seema again once again, and thanks sir for such a nice lecture.
Thank you.
Thank you, Dr. Nirmala. Thank you, sir. You have put everybody into such a wonderful gear And actually, it's like rejuvenating everything about ultrasound. And we have now certain questions in our panel, and we have great panelists with us. Can we have the CVs, Dr. Deepika? And we have with us Dr. Bavin Balakrishna. He's the master blaster, and Dr. Bavin, he's an infertility specialist, and he's an expert sonologist as well, who would not like his neighbor to buy a radio ultrasound machine because that is his bread and butter. And we have a sweet, simple, and sober Dr. Dimpy Gombar with us. And we have Dr. Gagan Singhal. She's the senior gynecologist from Narnol, and she has the zeal to do better and better. And we have dynamic and knowledgeable Dr. Nisha with us. So we have certain questions. Actually, after your talk, there aren't any questions, but still maybe like we want you to go on and on. So we would be passing on the question to you from each panelist. So we have the first question to Dr. Bavin actually. Sir has talked about 3D, and I'm just planning to upgrade my ultrasound to 3D and 4D now. But Dr. Bavin, the question for you is the difference between 2D and 3D. I put it other way. Can we justify what sir has told us with 2D also?
Good evening to the entire members, doctors, friends, seniors. Good evening to sir. It was indeed a very great informative lecture for me. In fact, we're meeting first time on a platform like this. Thank you, Seema. Thank you, entire Rewari Society, for allowing me to be on this platform. Two-dimensional and three-dimensional ultrasound. Definitely, if you have a 3D facility, I think that has to be performed. Otherwise, some things, and I think many things we started with as a two-dimensional, but definitely with the Doppler is justified. Is there any ideal follicular volume 3D?
This question will be to first we go to sir. So can you give us some hint, like we have 2D ultrasound and Doppler, so how can we justify our infertility diagnosis with that, sir? Ashok sir?
Once you've done your workup and you're doing just a follicular monitoring and you just want to time and make your, then at least until mid-cycle, you're comfortable with low-end technology. But the moment you reach mid-cycle again, you need that one high-end technology. So it's best to distribute. And so in your office, you keep a nice simple machine, and somewhere in the hospital, you keep a nice advanced machine.
Right.
That's the best way to do it.
Very right solution.
And whenever you have a problem solving, then of course you will use everything.
Right.
Yeah.
Next question is to Dr. Dimpy, ma'am. Is there any follicular volume on 3D to be seen on which can tell us that this follicle is now mature?
First of all, good evening to all the panelists, and thank you so much, Seema, and thank you for such an informative lecture, Dr. Khurana. The ideal follicular volume on 3D to be seen on the follicle maturity is, from the data, it is 13 to 23 mm for the good follicle to have a viable pregnancy. But Dr. Khurana will enlighten the answer better.
So?
Yeah, so what I find is that follicular volume is only easy to calculate when it's an automated machine. So I don't really calculate that. I just go by my diameter, and it's just so much easier. It correlates beautifully. By then I'm using my power Doppler anyway. So I've dispensed with doing the volume on 3D for the follicular volume. I go only by mean diameter.
Dr. Bhavin, you are doing infertility management. Basically, you're a gynecologist. So you want to add anything in this?
I don't use usually 3D on a regular practice, but definitely I justify when I see a suspicion on a cavity problem. That is the time I will shift to 3D facility. I will ask them to do a 3D ultrasound looking at the cavity, the fallopian tube, as what sir has said. But otherwise, regularly, no. But 3D will definitely make an important when I'm assessing the follicles, the number of the follicles, like in assessing the number, the size, that will be also good if you have a sonoase. We don't usually use this 3D on a regular basis.
Right, Dr. Bhavin. So next question is to Dr. Gagan, and I would like inputs from Dr. Bhavin and sir as well. Dr. Gagan, what are the signs of impending follicular rupture which you see on your USG?
There is increased vascularity seen in the ovaries, and the size of follicular size, it is somewhere around, you can say 20 millimeter. And so that's the physical thing that I see. But I would really like Dr. Bhavin to add more in.
The impending follicular rupture, we need to know what is the drug that we are using. A letrozole versus clomiphene versus gonadotropins. Gonadotropins usually will have a follicular rupture once it crosses 16 mm. Whereas it is a clomiphene, you need to go even beyond 24 to 26. And if it is a letrozole, again, you are somewhere around 20. So once we start a letrozole, I feel we should see definitely 10th day, 11th day, whether it is follicular rupture, especially if we are planning to do an intrauterine insemination. And the signs that I will look for is an immediate early follicular rupture where that follicle has suddenly disappeared, and there will be a relevant endometrial changes. That's secretory formation when you start closely looking at it, where we will start feeling that it is multilaminar. That appearance will start appearing. And if it was late, then I will see a crenated follicle, that is an early development of a corpus luteum. And how can we time IUI is based on this, what trigger is also given.
So elaborate on this point, Dr. Bavin, then we go to Sir.
Yes. The timing of IUI is based on these findings, yes. And secondly, when I've given a trigger, whether it is an LHRH agonist trigger or if it is HCG trigger, usually after 36 hours, we will have to do the timing. Earlier, I used to do on a regular basis an ovulation confirmation before the IUI, but now I do only for selected cases, not for everybody. But after 36 hours, call the patient in and then time it. What are the other associated features? As already sir has very well defined, the cumulus euphorus sign, all those things, definitely we can start appearing once we know we are close to the ovulation. Free fluid is also present and symptomatic also. Patient will definitely have some pain, especially we have to inform the patient if there is more than 3 follicles.
And cervical
Over to you, sir. Yes.
Over to you, sir.
You know, very wonderfully summarized points, and he brought up one more very important point that he emphasized, and that is to look at the endometrium. So the moment the moment the LH surge begins, the triple layer starts becoming echogenic, and that really tells you how much of a spontaneous LH surge has already happened, and therefore then to choose between your trigger and when to time your drug. For instance, we know that if it's not a down-regulated cycle, it might take a little longer. And then in some cycles which are not down-regulated, you might just realize that you never really needed a trigger because there was a spontaneous LH trigger. And then you start wondering, you know, she's a little more polycystic, she's a little more androgenic, I haven't really down-regulated her. Should I even give her the HCG? Should I give her LH? So that morphology of the endometrium that Bavin mentioned is very, very important. That I use that to see whether there's truly been a luteal phase beginning.
So sometimes it happens that follicle is not ruptured. There are no signs. Still the patient gets pregnant. So where have we gone wrong there?
You're absolutely right. If we look at a follicle and we turn down the gain too low, we'll never realize that it's actually a follicle that's the same size but full of echoes. Also, if it was a mature follicle of say 18 millimeters, then I would find peripheral vascularity around it. And if it's a very, very early corpus hemorrhagicum, then I don't find vascularity. In a corpus hemorrhagicum or a corpus luteum, the vascularity will appear 5 or 6 or 7 days later. So it's all a question of settings and studying with power Doppler. And of course, the additional signs like he already mentioned, which is free fluid. And sometimes we used to talk about capsular hemorrhage once upon a time where we look at the echogenic surface of an ovary. We no longer use that as a sign. We've dropped it. Basically, mid-cycle pain, I still use as a very frequent sign. And that's equally important. Did you get any pain? And the patient said, oh, it was terrible, doctor. I thought I was going to die of pain. I thought I was going to start my period all over again. So I still go by mid-cycle pain and all of that.
And so cervical mucus, is it of any importance on ultrasound?
I presume that question is for Bavin, not for me.
Right, sir.
The cervical mucus will be notified in the cervical canal very clearly once the E2 level starts correlating in the blood. And that is how we will see that fluid coming. But I don't think we can clearly decide that now is the time for ovulation. No, because it will be start opening even from day 8 onwards.
But like triple endometrium with cervical mucus, they conceive for sure. That is what I have
Yes.
observed. I don't know. I mean, I'm just a layman in front of sir. So the next question is to Dr. Bavin. Dr. Nisha, yes.
Okay.
Dr. Nisha, difficulties encountered in diagnosing a polyp. Dr. Nisha.
Thank you, Dr. Seema, for the question. So we all encounter difficulties while diagnosing a polyp on 2D scan. The polyps usually we see as a endometrial lesions, but we get confused because of the thick endometrium or to differentiate from a submucous fibroid. Though on 2D scan, we can differentiate by looking at the mucosal interrupted sign, because of polyp, we find a focal interruption of the normal mucosal lining of uterine cavity. And then we can add on Doppler to look for the pedicle artery sign, because these polyps are supplied by a single artery. But if we have a good 3D ultrasound, definitely it gives us a good edge to diagnose it with a more accuracy.
Right, Dr. Nisha. Sir has actually elaborated so beautifully that
Exactly.
you do the polyp and you put some fluid.
Fluid.
And if we combine it, surely, if we combine with the sono hysterosalpingography, so it gives an added advantage. Though it's not 100% needed if you can do a good 3D scan, but yes, the sono hystero will definitely add in diagnosing these polyps.
Sir, you would like to add anything, sir? Ashok, sir?
Yeah, so what I always do is I start suspecting it on the basis of clinical features, or in a patient who's not conceiving, or mid-cycle spotting or more than usual. And then we look for it on 2D. If I don't find it on 2D, I straight away move to a power Doppler and try to see whether I pick up a single vascular lead, a single vessel leading into it. Then I do a 3D, and 3D has inherent contrastiness. So when I find that inherent contrastiness, it shines more. That's the technique I use. And if I find that there's any distortion in that triple layer, I check which day of the cycle it is. And if I don't have adequate endometrium, I will just call them back after a few days. And if there's adequate endometrium and I don't find that there's this diagnosis, then I just put in a bit of fluid at the same time. So it's all step by step. And we keep discussing with the patient at the same time. And then, there's another thing, which is the patient side to it. What we tend to do in ultrasound is say, oh, I will charge this much for 2D, this much for 3D, this much for fluid, this much for this much for that. And it's like preparing a package deal for a tourist. That's not right. What we need to do is to move more and more towards, I have to give you an answer. And this much is how much it's going to cost. And I just give you everything in that much. That is from a practical aspect. In a general hospital, it doesn't matter. You don't have to worry about these things. But in private practice, you just tell the patient that, look, if I have to use a little more, then I will let you know, we can discuss it. And you go in 2 steps. Then I just use a simple 2D versus all the technology. And then nobody argues after that, because then they know they want an answer. And infertility patients, as you know, will never argue poor things.
Seema, I have a few suggestions.
Right.
There are certain encounters I think each one of us would have gone through. A gynecologist is treating a patient of infertility for 3, 4, 5 cycles. And afterwards, the couple changes the gynecologist, comes to another gynecologist, and often encounters that a polyp has been designed, it has been found out. The next question is, did that doctor miss this polyp? So I always give an answer. Polyps are one of the reasons that you may not have conceived, but even your infertility is hyperestrogenic. That can also polyp, and these are called subendometrial polyps. So don't be worried. Next month also I can see a polyp, maybe 2 or 3. And you're a polycystic ovarian syndrome. This itself can cause a polyp anytime. And one more thing is for all the doctors is when we use drugs like gonadotropins, there is a good tendency I have seen 3, 4 cycles later, I have seen myself where I've created polyps. And another suggestion is when we do a sonosalpingography, earlier when we started off, I was using pediatric Foleys and so many things, but now I use a very simple, locally available IUI catheter, which is not even 60 rupees, and it is very stern but soft. and it traverses the cervical canal, and I just push in 2 ml. And that is enough. As sir has mentioned, the endometrial volume is 2 ml, and that itself will delineate suspicious only. We do right now sonohysterography, and that uses just 2 ml saline. That is enough. And if it is very well guided, in fact, you can do a transvaginal, put a probe in the side. It will be more better rather than a transabdominal. Over to
Thank
you,
you, Dr.
Seema.
Bavin. It was such a nice share. And next question we have to Dr. Bavin only, and that is, what is the best modality to diagnose intrauterine adhesions? Because still, when we are not able to get pregnancy, somewhere we are missing on these adhesions, and every patient doesn't agree for laparoscopy, and somewhere we feel we are not justified. So ultrasound, MRI, if we don't write MRI, patient gets it done, because sir has very categorically said that MRI has no meaning, and we have seen with the wonderful radiologist in Rewari also that they diagnose everything so beautifully. But still, patients go to quacks also. So you ultrasound, MRI, SSG, HSG, or none of the above for adhesions. Bavin, what is your take on this?
This question is the correct reflection of how many of us have been attentive to listening to sir's lecture. He has given almost 15 minutes discussion on intrauterine adhesions,
Right.
and he has emphasized the role of ultrasound, how to do the ultrasound scanning of the endometrial cavity, looking at the waves, looking even things like where we can miss out, role of MRI, not justified. Yes, we can think of doing a sonohysterogram, but ultrasound, go to hysteroscopy. That is the best modality.
Right. What I got the conclusion that we need to do fellowship with sir very soon. So, sir, you would like to add anything in this, sir?
No, this is the most perfect, that you do a good ultrasound scan, you supplement it with 3D, you do a sonohysterography wherever you have a doubt, and you fast track them to hysteroscopy, because that's therapeutic as well.
That is the only answer. Right. Very right. Thank you, Dr. Bhavin. Thank you, sir. And next question to Dr. Dimpy. Uh, how to differentiate? Sir has shown it so beautifully, but once again to recollect, all that, how to
Whatever he has taught.
complete septum. Hello, from uterus diadelphus. Separate uterus, completely separate uterus from uterus diadelphus. Dr.
Now, diadelphus is a Mullerian duct anomaly, and there is a complete duplication of uterus, uterine horns, as well as duplication of cervix, with no communication between them. Sir has enlightened very well comparison between the separate uterus and uterus diadelphus. I think it's off to Sir to enlighten more on this aspect.
Yes, sir.
I think let me just add here. I think sir never spoke on this aspect about
I
uterus.
Yes.
Uterus diadelphus, and I was, yes, that was not added. He only spoke about bicornuate, unicorporal, everything. I was just thinking, I wanted an answer on this.
Exclusive, but we could get it from Sir's talk how to get it, Bhavin.
Well, no, but he's absolutely right, because you see, one of the slides I went through fast because I realized I was taking too much time and eating into everybody's time, was this, that we no longer have a uterus diadelphus anymore. We divide them into uterine abnormality, cervical abnormality, and vaginal abnormality in the new Esche classification. So when you have a complete septate uterus and a complete and a vertical separation of the entire cervix into two, that is then a diadelphous uterus. So we've thrown out the diadelphus completely, and it's just referred to as a complete septate uterus with a septate cervix. So that then is then treated as a septum.
Dr. Bhavin, you wanted to add something?
Nothing more.
Okay.
Nothing more.
Thank you, sir. And next question is to Dr. Gagan. What is the optimum time to diagnose all these anomalies in the uterus in the menstrual cycle, Dr. Gagan?
Ma'am, it's somewhere around the ovulatory phase and the early luteal phase. And as sir had said, very beautifully said, that we can even measure the endometrial volume. As the endometrium is ripe at that time, we can very well identify the endometrial myometrial junction, and we can even diagnose something like tuberculosis of the endometrium and the septum inside the uterus and many other things.
So, over to you, sir, Ashok sir.
Yes, so you see, we need a substantial amount of endometrium. So you must at least try and do this sometimes you can miss it completely when you have a thin endometrium, then you can miss out a lot of things. But if you have better equipment, you can manage even then. But so if I have, say, medium end or low end equipment, then what I would do is try and look for all of this from mid-cycle to mid-luteal onwards, because then I have a nice juicy 9 millimeters, 10 millimeters, 11 millimeters, and I can use my low-end technology to actually see this. So that's easy, but with high-end technology, you can manage it anytime.
Right, sir. Thank you, sir. Next question to Dr. Nisha. What is the incidence of uterine anomalies in infertility patients? How many patients you come across, Dr. Nisha? Dr. Nisha? Hello?
Yeah. If we talk about the findings on ultrasound, then it's roughly in 7 to 8% of patients we find uterine anomalies. And in those also, I would say roughly 75% are the separate uterus.
Okay, so
and then of course I know that the first thing that is to realize that which are the significant clinically relevant anomalies and which ones are not, and we've discussed those at length, of course. But if you really were to sit and analyze series, the interesting thing is that in the infertility population, we do seem to have a much larger incidence of Mullerian abnormalities than in the non-infertility population. And therefore, it's very important to start by presuming that there could be an anomalous uterus. And then you start using subtle signs. When I do my uterus evaluation on 2D, do I find an increased transverse diameter? And in that case, it could be either a bicorporeal or a septate uterus. Do I find a uterus that overall is a little smallish, a little less than 6 centimeters long, a little less than 2.5 centimeters thick? Then I start looking at a hemi-uterus, the original uniconnovate uterus, and then you gradually build it up. So you remain sensitive to that and then build it up.
So that is, I think, complete the answer. And next question to Dr. Bavin again. Dr. Bavin, you have to share in detail what, so had talked about this again. And as a gynec, we want you to share your experience. One, like who had poor endometrium and then low dose aspirin, sildenafil, pentoxifylline, all these, what ABCDs, what were they effective in improving the endometrium?
I will put it in this way. One is the good clinical practice, one, and second is the evidence-based medicine. The evidence-based medicine does not give support for any of these, whether it is low-dose aspirin or pentoxifylline or many of this. So there are plenty of papers, and the evidence, what I look at is the Cochrane-based evidence. Even for recurrent miscarriages, preconception, giving low-dose aspirin really does not make difference. But my good clinical practice is also same. I have used all these masalas once upon a time. I have used. I'm not denying. I confess that I've used all sort of masalas. In fact, when I used aspirin, I was getting bloody fluid also at the time of OPU, when I was doing an oocyte retrieval. The low-dose sildenafil also have been used. But all I have given up, I think, over the last many years, it is just given up. But sildenafil, definitely, I still stand a role only that is related to significant fetal growth restriction. There I'm being still using it, but if it is purely a placental uterine factor which is showing a notching quite early, otherwise that is a symmetrical IUG, or otherwise no. Low-dose aspirin, I don't use it pre-conception. It is only used in conception to prevent preeclampsia, which is a evidence-based medicine.
So before I ask you, we have been using all these boosters off and on, and the endometrium does improve at times, but no pregnancies. So what is your take on this question?
You know, there are 2-3 things that you have to be careful about. One is that, yes, it does not improve implantation rates. There is no doubt. That homeopathically, there will be some success, no doubt. The biggest tragedy happens in our Indian scenario where you take these reports to somebody and say, oh, but you know, there's this endometrium that is not so nice. Did your doctor not put you on to low-dose aspirin? We will build up your endometrium. We will do this and we will do that. What you have to do is, when you find the clinical problem, counsel the patient that, look, there are these 120 different recipes which we can try, and the wonderful masala that Dr. Bavin was mentioning. But the fact is, none of them is proven. And therefore, although I would love to give you this cocktail, I'm not sure. I would just go by science and then I'd do it, because this is marketing very important when failed cycles go to somebody else. And because you're so honest with the patient will never take this question then to somebody else, because they already know, and you already told them that, look, I'm not using it because there's no scientific evidence. So that is extremely important. The other thing is that we know that the placebo effect will occur beautifully. So it's nice to give them something, and you don't have to tell them. In terms of low dose aspirin, I fully agree that we have, we certainly overdo that and expect this. There was a lot of low dose aspirin that was used in the 80s and the 90s, and even bosses like Alan DeCherney had said this is the big unique drug, etc., etc. Sildenafil is one of our biggest hassles. A lot of girls that have used sildenafil in the first 6 weeks of pregnancy are now, for some reason, coming up with teratogenicity and a higher incidence of stillbirth. I cannot afford a stillbirth in an IVF patient. I would never ever use sildenafil again. Anyway, the most unpleasant drug to use, no proven effect, and it has a negative effect on my pregnancy. I would just not like to use it. And then, of course, a lot of sonologists now say, look, I will put your protein-rich plasma into your endometrium. It will grow tonight. I will put it into your ovaries and you will get 25 more follicles in the next month. We go step by step. These things are okay for Dubai. These things are okay for off the coast of Italy, etc., etc. Let's wait for a few results and then we will talk more about all these additional things. I would fully agree with Dr. Bavin. We have science, we have evidence, and we have quackery.
Thank you, sir. It was such an informative share. Thank you so much, sir. And next question we have to Dr. Dimpy. So we have talked about more about the follicular size and the number of follicles. So what should be the maximum thickness on day 2, day 3, beyond which you would not like to stimulate that patient? Dr. Dimpy.
I think it is endometrial thickness is 6 mm, but the more information can be given by radiologist Dr. Khurana.
So we want you to enlighten us.
I think I went and psyched everybody. That's not fair. But you see, I use 5 as a cutoff. Right. And so anything that is 6 millimeters or more usually reflects a dysfunctional change. And it might even get shed off on day 6 or day 7. So then I would like to reevaluate. But we also look at texture and see how thick it is and how echogenic it is. And you know that there's a lot more that needs fixing rather than using that cycle, say for an IUI cycle. If I'm going to be using it just for an ovum pickup cycle, then I would say I'm just doing my ovum pickup. It doesn't really matter. But usually it reflects that something is wrong in the endocrine milieu and therefore this is happening. And so I use 5 millimeters as a cutoff. But otherwise, I would always fine tune it into the clinical perspective.
Right.
May I, Seema?
Yes, sir.
Seema?
Yes.
In fact, the maximum thickness on day 2, day 3, scientifically, it is always kept at 5. Why? Because it correlates with the 50 gram, that is a measurement of E2, estradiol. Okay. So beyond which our cancellation of an IVF cycle or a stimulation cycle would occur. So it is better to keep it at 5, that is the cutoff. But if we see 6 and in the absence of a residual cyst, I think I will call her again after 1 or 2 days, as sir said, and review once again. Maybe I will start a late stimulation. And of late, last 3-4 years, we have come across very good concept of ovarian stimulation, but not on a routine basis. This is only selected patients where we can start stimulation at any point of the cycle. Irrespective of the endometrium, you just need to have the antral follicles and no residual follicle formation. You can start stimulation at any, but those is again reserved, selected for that group of IVF patient who comes, be only there for 30 days. They want to go back and maybe do a later frozen embryo transfer.
Only for the frozen way, we don't take endometrium into consideration. That is what I get from sir and you. Yes. Right. Thank you, Dr. Bavin. Next question is for Dr. Gagan, but I think sir has talked in great detail about what is Doppler mapping actually and relationship with implantation, Dr. Gagan?
Ma'am, the blood flow of the endometrium tells regarding the receptivity of the endometrium for the implantation of the fertilized egg. As sir had said, that elevated uterine artery PI or RI means there is there is going to be a low implantation and pregnancy rate. I think sir had cited the PI as to be more than 3.109, if I remember it correctly.
Right.
But I've gone through few papers. Those the results were very conflicting. Some papers they were saying it is you can predict an outcome, but some papers said no, you cannot predict an outcome. Sir will tell better. Over to you, sir.
Absolutely right. The reason is that when we look at endometrial receptivity, we've never really been able to understand it so well. And so we know that there are certain factors where we know that we are extremely likely to have a poor outcome. And yet there are certain factors where we say people can implant. I've seen implantation in pregnancies where the endometrium was 5.5 millimeters thick. And I used to keep saying we're wasting these ova, we're wasting these ova, why are we using these embryos? And they used to take. So it's not one single factor that is either a negative factor. And therefore very often we've had in ultrasound and in gynecology, a lot of scoring systems that have come up. I'm never in favor of a scoring system, but the fact that we have so many variables for endometrium receptivity means that no one factor can ever be a determining factor for cancelling a procedure. So we use endometrial thickness, we use endometrial morphology, we use endometrial volume, we use 2D vascularization, we use 3D vascularization. Of course, we use the cavity shape. We use uterine artery. We use also whether there's subendometrial vascularization, which people used to use. I don't believe in it anymore because again, for the same reason. And that applies to all of these, that if we have good subendometrial vascularization in the myometrium, you will have a pregnancy, but even with zero vascularization, you will have a pregnancy. So therefore, none of these is an all or none parameter, and you always consider it in perspective. I have a very, very good looking endometrium, beautifully vascularized, excellent volume, excellent peristalsis. Everything is wonderful. I will go ahead and then do an IUI or carry out an embryo transfer. One single factor, but if I have a series of failed IVFs and I keep getting consistently poor uterine artery value, then I know I have to do something to improve my uterine perfusion, and then I go right back into endocrinology. I'll go back into immunology and make sure that there is nothing that is resulting in a vasculitis. And I relook at tuberculosis all over again, because after all, my biggest problem in life is tuberculosis, because it's not just a disease of the end organ, it's a disease of the vessels. With tuberculosis, you have an end arteritis. And the end arteritis occurs in the endometrium, it occurs in the ovary, it occurs in the spiral arteries, and therefore gets reflected in my uterine artery. So then I start looking at the reasons why this is happening. So it's always in perspective.
Thank you, sir. And Dr. Nisha, you can just add, actually, sir has explained, is there any added advantage of endometrial volume over endometrial thickness, Dr. Nisha?
Hey, Dr. Seema, we all have been using endometrial thickness as gold standard for planning our embryo transfer, where we take as the cutoff of 7 mm. But yes, there are few studies which have shown the relation of receptivity with the endometrial volume, which says around 3 to 5 cc volume of endometrial cavity is optimum for the good receptivity. But there has been no study which correlate the endometrial volume with the pregnancy outcome. So I would still say endometrial thickness along with a good blood supply is still a better indicator, or we might need further studies to work on the endometrial volume.
Right. So,
Seema, endometrial volume versus endometrial thickness. Traditionally, endometrial thickness always has been justified. Endometrial volume is a new concept which is coming up, but it is not available for on a very good level 1, level 2 to all centers. So we should stick to endometrial thickness, but I feel we should stick to even endometrial morphology. Look at the morphology, multilaminar pattern. But if you have a straight echogenic pattern and it is measuring 7 mm, no. If it is a 5 mm and it has got a nice multilaminar luteal changes, yes, we should think of and giving a positive vibes to the couple, and also we should go for an embryo transfer. Earlier, we were not doing embryo transfer, not more than 7. So that 7 was the golden thing. But I think in failed implantation, failed IVF, their uterus is definitely on a smaller side, chronic anovulation. The endometrium may not even go beyond 7. I think we are justified to proceed. And that is also given documentation by a very good scientific paper. Endometrial thickness is not to be taken in a very big manner at all. So don't deny the patients not to transfer or even go ahead with their pregnancy.
So what is
Over
the
to you.
cutoff volume which is recommended?
More
Is
than 2, this is what
3.5, I think they have seen no pregnancies if the volume is less than 3. It's just the studies which says. I think we need to
2 point.
do more work
Will
for
elaborate,
this.
sir?
I think sir's lecture mentioned 1.9.
Yeah,
Anything?
1.59 or thereabouts. And
Yes.
the one place where I do find volume a little more useful is those anomalous uteruses, where
Okay.
adenomyosis and it just squeezes the endometrium out and you don't get any response there. Or you have a septate uterus and you wonder, should I operate, should I not operate? And again, it's useful. In the hemiuterus, the unicornuate, I find that a little more useful. But again, like I said, by itself, never something to cancel a cycle. And then suddenly you find that a thin uterus, like Bavin just said, is a very juicy uterus with a lot of vascularity, a thin endometrium. Then why should I cancel that cycle? It just might just take. And then, of course, I don't do the other thing. Won't go to the other end and say, look, maybe I'll transfer 3 embryos and one of them will take. No. I will still do a single embryo transfer and hope for the best. So it's not that I will try to overcome one negative factor by trying to add more embryos. No, all I will say is I will do my 1 embryo transfer. I'll preserve the rest. If it doesn't happen, okay, then I'll try one next time. And then when I'm down on my number of embryos, then I will start experimenting with everything else. Then I'll go ahead even with my plasma-rich protein injection, etc., etc. But it's all graded stepwise, and we must realize there is no fire. The baby is going to arrive, and the baby is going to arrive.
So one more question here. What is your follow-up of adenomyotic patients who have been operated somewhere and then they for infertility treatment? Because we don't get many such cases, so we are not aware, experience-based, like what is the prognosis in patients with adenomyosis as such, untreated or operated, sir?
If you ask me on the follow-up,
Yes,
we do realize that adenomyosis is not a single disease. There are adenomyoses which are immunologically active, and those are the most difficult. And there are adenomyoses that are consequence of the hyperestrogenic phase, which are actually easy to handle. And the really big study that we're doing now, which hasn't been published as yet because we're still trying to get data, is to try and assess the elasticity of the myometrium on ultrasound by doing elastography and an artificial intelligence to try and see how dense is the changes in the myometrium. When those come out, we'll talk more about adenomyosis. Otherwise, adenomyosis is a matter of luck. You can have the ugliest uterus with adenomyosis and you can happily have a baby, and you can have a subtle adenomyoma sitting somewhere and there will never be an implantation. So we must realize that we don't understand this disease from its immunologic aspects.
because our experience in IVF has been very bad with adenomyosis. It's almost like a failed trial. Dr. Bavin, you would like to add something here?
Adenomyosis localized, definitely I have not seen much problem. But if it is diffuse adenomyosis and very subendometrial, myometrial cystic appearances, I don't, and they have even large cavity.
Right.
So I have seen, even if they get a pregnancy, they will definitely turn out to be either a hypertensive disorder or a fetal growth restriction disorder. So I always tell them, look, I mention a note in my paper saying, kindly follow up for predicting all these fetal abnormalities. So, and that will only come after 26 weeks. Till 26 weeks, she will not be having any problem. They will be doing very well. So patient will say, why suddenly something came up in the end? It is not in the end, it was there in the beginning. And that was there before the pregnancy.
So you mean they should go for surrogacy then?
No, this is not a surrogacy plan. No.
What is your recommendation for them then?
I do the usual routine step 1 ovarian stimulation. I do the routine IUI. I don't take them as a considerate, but I tell them, yes, this is an adenomyosis. And unless it is very painful, don't try to operate, because adenomyomectomy has even a very worse perinatal outcomes.
No,
Especially,
now, if you look back, there are patients with 6 or 8 abortions, then what do we do for them with adenomyosis, recurrent abortions? What is the treatment
In
modality for them?
such patients, I immediately don't put on a very good treatment. I put them on a psychologist plan, because that is the first thing. I need to alleviate that thing from her head. She is not the problem. The seed is the problem. Look at the man. So that itself creates a lot of psychological differences. Give her time. Yes, it makes a big difference. And it is not the uterus alone. It is not the lady alone. It is a man, and the seed will decide everything. So the seed, whether the seed is very good, even if the soil is bad, seed will pick up. If the seed is not good, even then the soil is very good, seed is bad. That is what we have to in fact imply to the couple, and they will also feel much more happier. Yes, we have a treatment. Second, I also give them minimum of 3 cycles, because the ovulation that we are seeing in the month of, say, September, it has actually, sir has mentioned, primordial follicle starts 150 days prior.
Yes.
So 150 days is approximately nearing to 4 months and above. But even if we give them 90 days, we are definitely going to give them, even the oocyte quality will come up, give them good diet, just try to deviate, talk to them. That all makes big differences. And then start with your big treatment of stimulation, IUI, or medical assisted technology.
Agonist depots, do they make any difference? Gain
Agonist
energy.
depots, yes, I use it when I have to do an IVF or if she has a pain, otherwise no. But now I have got a new drug. That drug is called Visan. And I must confess that Visan gives definitely better, much more pain relief. The quantum of pain relief is much more better. But don't make a drug to be used for long time. You take a call, patient need not. Suppose I have seen a patient for 3 months, I have given Dynogest, and the patient is still having pain, and she comes to Seema. Seema should immediately re-evaluate clinically, sonologically, psychologically, personal history, whether this drug is needed or not. Otherwise, stop the drug, go for another modality of treatment. So I have seen couples who have been painful. They are constantly bleeding 6 months, 8 months. That should not be allowed.
Right, Dr. Bavin. Precisely, it was the very correct take-home message. And we have, sir, 2 or 3 questions from audience, which I would like you to address. So, Dr. Harsha Sehgal has asked, what do we call hypoplastic uterus criteria? When do we call hypoplastic uterus? What are the criteria to call a uterus as hypoplastic?
Yeah. So there are some old words in literature that we need to throw out, really. And basically, the hypoplastic uterus has to be differentiated from what we call an infantile uterus and what we call an atrophic uterus. So the ones in which the anterior-posterior diameter of the cervix is larger than the anterior-posterior diameter at the subfundal region are the ones that we call the infantile type. And those are the ones which again is a misnomer, because when they are actually on breast milk, the uterus actually does not have an infantile shape. So that is something that happens when they stop having breast milk, and you will find uteruses in children like that. The anterior posterior diameter at the fundus is much less than that of the anterior posterior diameter. That is the infantile, and we get it out of the way completely.
Right.
Then we have to differentiate between atrophy and a hypoplastic uterus, which actually we cannot, because they look identical. They have an adult morphology. There is a pear-shaped uterus with a wider fundus and a smaller cervix, relatively speaking. And then we used to use absolute measurements, but those used to be mathematical measurements with absolutely no clinical background. What they did was that they took all uteruses and they decided that everything that was lying below 2 standard deviations or the third centile would be declared hypoplastic uterus, which makes no sense. Because you could have the most beautiful uterus which will respond once you start stimulating or once you start ovulating. So we do not use the word hypoplastic anymore. We just use the word small.
So there is no size criteria, like if it is 4 centimeter
We
length
used to have
or...
a 4 centimeter length, which we no longer use.
Right, sir. Yeah. Thank you, sir. And another question from Dr. Arti Luthra, that do you think that 3D transvaginal probe gives better results than a 3D transabdominal?
Oh, there's no comparison at all. Because you see, the abdominal transducer will always work at a much lower frequency. So I might have at most a 6 megahertz transducer, or if I'm really lucky, an 8 megahertz transducer, but then I don't get penetration. with an 8 megahertz. So the maximum I can use is 5 to 6. And the resolution with that is exactly 40% compared to my 5 to 9 megahertz. Because I'm using a 9 megahertz frequency, or at least a 6 to 7 mean frequency. So therefore, I might use it in the patient where I have no other access, which means I cannot do a transrectal scan, and therefore I didn't do a vaginal scan, but I would never ever use a transabdominal scan for a fine diagnosis. And it's the same thing for when I do my sonohysterographies. I always empty out the bladder and I put the catheter in place, and then I use a transvaginal transducer to get my information.
Thank you, sir.
I have something here, Seema. When we are treating infertility, we use a condom cover most of the time. But there are some condoms with spermicidal on the surface.
Very
And I have changed to
probe
probe
cover.
covers.
Yes.
I think that should be, earlier the condoms did not have spermicidal. I think I'm seeing more of condoms which are having spermicide. So probe cover would be ideal. And again, in fact, it is very important. There are many ladies who have dermatitis developing because of this probe cover, or again, then I think the best we could do is use a transabdominal, and we have now very good resolution machines. It gives very good appearance of the ovaries and the follicles.
Right.
Only in those patients, yes.
Thank you, Dr. Sir, you were saying something, Ashok sir?
You know, latex allergies, you have to be very careful of latex allergies as well. Also, of all the lubricants available, ultrasound gel is also spermicidal.
Yes,
So
yes.
when you're looking at bad sperm, which is the usual story these days, I feel very upset. And the only thing that really, and this I speak out of experience, is coconut oil. Coconut oil is non-spermicidal, non-allergic, and it makes the intercourse much easier when they go home. Everything else works well.
We could popularize it in Kerala then.
It truly works wonders, and we've never found allergies. So when I use probe covers and they're little dry, then I use coconut oil with that.
Sir, there are some questions which you already answered, like Dr. Arun Kumar has asked, do all septums need resection, or what size of septum needs resection? I think you answered. There is one question from Dr. Shivani Walia. What PRF should be used to rule out endometrial polyps?
Oh, you know, it's not the PRF really. The PRF, we talk more in terms of color. And for that, we use a standard 0.6 kilohertz frequency that we like to use for that, because that gives a color cutoff accordingly. But again, for color, it's the whole setup that we must adjust our color gain, we must adjust the PRF, we must adjust the total gain, and we must adjust our angles.
So, sir, the list is endless, but somewhere we have to stop. And it's been like meticulously and so patiently you have answered all the questions. We look forward to many more meetings, and I would invite our young radiologist, Dr. Deepak Yadav, who is also very academically oriented, and he's the best person to be here with. Dr. Deepak Yadav, for vote of thanks for all the wonderful presentations, and my special thanks to Sir and Dr. Priti, Dr. Poonam, and Dr. Nirmala, and all the wonderful panelists. So over to you, Dr. Deepak. Are you there?
Yeah, ma'am. Sure.
Yes.
Thank you, sir. It was such a wonderful presentation, and we sincerely thank you from bottom of our heart. And we must all admit that today we are all going home more enlightened and more enriched after hearing this lecture. So thank you so much, sir. Particularly those 3D rendered images we haven't seen. I have been trying that those kind of images in my machine too, but nobody can match you, that is for sure. So thank you so much, sir, and thank you again, and from behalf of Rewari Obs Gyn Society, sir. Thank you so much, sir.
Thank you. It was a pleasure indeed.
Thank you, sir. And I really hope that we have such more meetings. I know your time is so, I mean, you are always running short of time. We have appointments 3 weeks, 4 weeks waiting. But it was such a pleasure to be with you, sir. And we would definitely look forward to many more meetings with you. Thank you, sir. And I would like to thank Jackson Pal for arranging this webinar for us so beautifully. And thank you once again, all our panelists, our chairpersons, and Team Jackson Pal. Over to you, Deepika ji, to thank sir for this wonderful presentation, wonderful evening. and so much time you have spared, sir. We have so much to learn from you. Over to you, Deepika ji.
Yes, thank you so much. Thanks a lot to all the panelists, to all the experts here. On behalf of Jackson Pal, I am Dr. Deepika, along with my teammates, Dr. Vipin and Mr. Amit Saxena. All of us are thanking the scholar of the day,
Yes.
Dr. Ashok Khurana, sir, for sparing so much time to be with us today. All the chairpersons, the panelists, everybody who has made this webinar such an interesting one. And thanks a lot. We would be seeing you again in our next webinars. This is Jackson Pal saying goodbye to all of you. Thank you.
Super scholar with third eye, so we
Yes.
agree now. What you see, nobody can see. And even we are feeling some vibration, middle of two eyes, that something is happening now after your talk. Thank you, sir.
Thank you. It was a pleasure joining all of you.